Neurology Quiz number 116. Describe the etiology, clinical features, pathogenesis, and treatment of the purple glove syndrome or PGS. Purple glove syndrome or PGS is a rare but serious adverse reaction associated with intravenous administration of phenytoin. It typically presents with pain, swelling, and purplish discoloration at the injection site, which spreads to the distal limb. Clinical features in progression, stage 1 within 2 to 12 hours. The first signs include a well-defined bluish-purple discoloration around the IV insertion site. Small petechiae may also appear on the fingers or palms. Stage 2 within 12 to 24 hours. The discoloration and swelling may extend both distally and proximally along the limb. In this stage, more severe local symptoms may develop, including skin blistering, sloughing, and ulceration. In some cases, arterial compromise occurs, leading to skin necrosis, compartment syndrome, or even gangrene. Here, the picture on the left shows bluish discoloration and swelling of the hand in PGS, while the picture on the right shows the left hand of a patient with swelling, edema, and bluish-purple discoloration consistent with PGS. This is another example of purple glove syndrome characterized by purplish-black hand discoloration accompanied by edema. This picture shows acute stage of PGS with dusky digits and extensive blistering of the hand and distal forearm. This image shows the right hand of an 81-year-old after intravenous phenytoin administration with PGS showing extensive blistering. Stage 3 is the recovery phase. Over the course of several weeks, the soft tissue changes gradually resolve. If significant necrosis is absent, full recovery is typically achieved within 1 month. Pathophysiology, the exact mechanism of PGS remains unclear. It is most commonly attributed to leakage or extravasation of the highly alkaline phenytoin solution into the surrounding tissues. Phenytoin is poorly soluble at neutral pH, requiring addition of sodium hydroxide to increase pH along with propylene glycol and ethanol to enhance solubility. All three additives are known to be irritating to soft tissue. However, PGS has also been reported in the absence of clear extravasation. One proposed mechanism suggests that the high alkalinity of phenytoin may cause vasoconstriction and thrombosis, ultimately leading to leakage into the interstitial space. Comparison with phosphenotoin. Phosphenotoin, a water-soluble prodrug of phenytoin, is formulated at a neutral pH and uses a less irritating vehicle. Due to these properties, it is believed to have a lower risk of local reactions such as phlebitis and PGS. Nevertheless, cases of PGS have also been reported with IV phosphenotoin administration. Incidence and risk factors. The incidence of PGS after IV phenytoin administration is estimated at 2 to 6%. Risk factors include age more than 60, female sex, sepsis, peripheral vascular disease, chronic debilitating disease, and frequent or high-dose IV phenytoin use. Prevention strategies. Measures that may reduce the risk of PGS include using IV catheters smaller than 20 gauge, administering phenytoin through large bore veins, flushing the catheter with normal saline after use, prompt removal of the IV catheter at the first sign of symptoms, whenever possible using oral phenytoin instead of IV administration, although rare cases of PGS have been reported with oral phenytoin as well. Treatment management of PGS is primarily supportive and includes discontinuation of IV phenytoin, limb elevation, application of heat or cold packs, pain medication. Most cases resolve within days to weeks. However, severe cases may require emergency surgical intervention, such as fasciotomy to relieve compartment pressure and restore circulation. In rare instances, amputation of the affected limb has been necessary. This picture shows a case of PGS following IV phenytoin. 2 days after the infusion, marked discoloration and edema had involved almost the entire right hand, as seen in the top picture. By 2 weeks, the condition had begun to resolve, but considerable discoloration and edema persisted in the fingers, with some areas of healing ulceration in the fingertips, as seen in the bottom picture.